expression, she has showed all type of lenses, and the nucleus comes like magic. So every time. So I will now request Dr. Professor Kamaljeet Singh sir. He is going to speak to us for the SICS. Yes, we can achieve 6 by 6 in SICS. Kamaljeet Singh sir. Thank you.
Thank you so much, sir. Thank you, sir, for giving me the chance to speak in such a beautiful auditorium. Actually, basically, since we are doing SICS most of the time, how to achieve 6.6 and N6 is important. We are using a cheaper technique, a very good technique, but very cheap, and we are using non-foldable IOLs. So it's important to plan your surgery so that you get 6.6 and N6 with a monofocal IOL. It's very simple. This is what I practice even in phacoemulsification, where the patient does not want multifocals or trifocals. I always prefer this technique. Most of my patients, we are doing around 100 to 150 cases in the department. And 80% of them, although it's all surgeries are free, they opt for SICS. Cataracts are very hard, and phaco is not possible in those cases. So how to give them 6.6 and N6 vision? It's very important. You can try multifocals, trifocals, or accommodating IOLs. But in our Indian context, where population, 80 crore population is taking 5 kg atta from our Prime Minister's fund. So I think that a costly surgery would not be good for all our patients, even where the children don't take care of the elderly. So what you can give to the affluent patient, those who can afford, it's fine, you can do whatever feel. But basically, monovision is a concept that you can use in your surgery, and we'll give 6.669 vision for distance and N6 for near. The simplest thing is to plan the dominant eye emmetropic and non-dominant eye myopic. So what are the advantages of implanting monofocal IOL? These are time-tested IOLs. PMMA IOL is the best, causes least PCO, and in case you need, it can be explanted, which is not needed in SICS. You don't need to explant, whereas multifocals and trifocals at times need to be explanted because patient is not very happy. Monofocal IOLs are gold standard. Clarity is best in monofocal IOL, contrast, sensitivity, and all other qualities. If you see, you will find that PMMA lenses, those which we have operated 30 years, 25 years back, they come without any PCO and without any trouble of contrast sensitivity or photopsia and all those things. So my aim is monofocal with monovision. And the term is, actually I don't agree with this term of monovision. Monovision means that patient is seeing from one eye. Because what happens is that if the difference between the two eyes in refractive error is 2 diopters, the binocularity is maintained. All studies have shown this. So this is what you should have in mind, that the binocularity would not suffer if the difference between the two eyes is up to 2 diopters. And in many cases, even more, the patient is comfortable and does not have any diplopia or all other things. So what are the candidates for monovision? Any patient, young or old, female or male, they can be taken up for this surgery. Plan to make them myopic in the first eye. What happens is that since most of our patients are elderly, they would like to read newspapers, they would like to see their mobiles, they would like to see their laptops. So what you have to do is that first eye which you are going to operate, you make him myopic, a little myopic, say 1.5 diopter. Target refraction should be 1.5, 1 diopter. So he'll be able to read most of the time. And for distance he might get 6.12, 6.9 vision. So you can easily give this. And then you check the refraction post-operatively. And then plan the other eye. So based on the post-operative refraction that you get, you have to check the and plan the other eye's target refraction. So what I do is that if supposing I have done a targeted in the first eye minus 1.5 diopter, and supposing there is some change in the refractions, he becomes emmetropic and your calculation is not good, so then the other eye I'll make myopic. So he'll be able to see for distance from the first eye, and for from the near objects from the other eye, you make the other eye myopic. So this is a very good plan, and you can continue with this. Hypermetropics, they have never seen an elderly patient hypermetropic. Usually they have not seen anything for distance clearly, or for near they are miserable. So what happens is that if you give them a vision which is even emmetropic or little myopic, they feel very happy. Most of these patients would be very happy because they have never seen after 40 years anything for near. So you make them a little myopic, they will be very happy. So this is what you should plan in a hypermetropic patient. So binocularity, as I have already mentioned, that if the difference between the two eyes is 1.5 to 2 diopters, so the binocularity does not suffer, the stereo acuity is maintained, and this has been proved by several studies. Profession should also be asked from the patient, because many a time these days IT is the patients are from IT, patients are doctors. Like when we operate, if we can see the tray and look at the microscope without glasses, we'll be happiest, because many a time the assistant is not there and you are fumbling there on the tray. So a doctor or IT person, or for that matter a female housewife, those who work in the kitchen most of the time, they would be happier if they are made a little myopic. So this is what one should plan, so that the patient is happy most of the time, and is and in elderly patients, say 70 years or more, they have to stay in the rooms most of the time if they are moving out. Not like Dr. K.K. Mehta, who operates even after 70 years. So what you have to do is that you make them myopic, because they will be staying in the room because of the other ailments. So if they are there in the house and they can easily read without any glasses, they will be happy, and they will be there in a small 10-feet room, and so they can watch the TV also without glasses. Like I am myopic, and I can see my laptop here, and I can see you all also. My distance vision is slightly 612. So I am very happy without any glasses. I have never used any glasses for near. So these are some of the things that you can do. Housewives, as I have already mentioned, that they are the happiest because they have to do the makeup also. If you make them myopic, they can see on the mirror in front, and they can easily see their face, and then apply the mascara and whatever their lipsticks and whatever they apply there. So that can be easily done by. So housewives, they are very, very happy if they are slightly myopic. Then how do you test the ocular dominance? We say that the dominant eye should be made emmetropic. This is the usual teaching. So what you do is that you simply make a triangle of this. Like this, you make a triangle, and with each eye you ask the patient to look at the watch, and whichever is clearer, that is the dominant eye. It's very easy. You close one eye and see the watch, and through the other eye you see the watch, and if the vision is good, then one can tell that which eye is dominant. The other test is called fogging test. That can also be applied. You put a +2 diopter lens and ask the patient to look at the near objects, and whichever is worse, that is the dominant eye. So these things can be done. And the other important thing that we have to remember is that in multifocals, the brain, they say that it takes time. You keep on explaining your multifocal patients, कि अरे नहीं अभी थोड़ी दिन दिखेगा, brain adapt करेगा, and then you will be able to. You keep on convincing him. Patient is not happy in initial some of these patients. So here the adaptation does not take much time. Patients are happy on the 3rd, 4th day, and they can easily see the objects as they want. So this can be tried, and simplicity is the best, and I would say that continue with your monofocal IOLs and give 6/6 and N6 vision to your patient with this idea. Thank you so much.
Thank you, sir. Very practical tips and for everybody.